Okay, here we are. Welcome. Week 2, part 2 of psychological disorders, in particular around, we did last time, and the part 1 was assessments. And here we're going to look at the classification techniques or the strategy and what's used most frequently right now. What's the most popular method is by using the DSM-5, sorry. And it's a classification strategy, and it's helping figuring out how to sort of separate the different classifications or psychological disorders and how to tell them apart and what actually makes it more likely that one person fits in an area or has a psychological disorder, in fact, when you don't have one. And so that's what we're going to start on, and then we're going to look at treatment philosophies in a broad sense, and it'll resemble some of the theorists in that perspective, and so it'll sound somewhat similar, but it puts it in a more practical way in how it's being used as a treatment method for different psychological disorders. And I won't be very specific about them. I'm going to be more general. We'll look at the specificity of the treatments when it comes to looking at different psychological disorders. All right, let's get on with this, and good luck.
So how do we classify abnormal behavior? And as I mentioned earlier, the DSM-5 is the newest. I think it came out in 2013, and it's what we use to classify and organize psychological disorders. Now, what's really, really important to pay attention to and to remember, and clinicians need to keep it at the forefront of their mind, is that we don't, we classify disorders. We don't classify people. That's the image there of label jars, not people. By labeling somebody as the schizophrenic, it puts a whole it defines the whole person by a label, rather than indicating John, who has schizophrenia. That's not labeling somebody, that's stating something that is a part of a condition by which they have. So classification is at the core of the scientific enterprise. Labels make communication about psychological disorders possible. It's not trying to fit people into categories. It's in fact trying to help determine what would be the best course of action to help them. An attempt to define and discover actual diseases, in this case, mental or psychological disorders. The DSM uses specific diagnostic criteria to group patterns of abnormal behaviors that share common clinical features. Strengths of the DSM include its use of specific diagnostic criteria to provide a picture of that person's disorder. The weaknesses include questions about reliability and validity. The DSM-5 absolutely needs to be valid and reliable in order to be used as frequently as it is. So it has a degree of, it is valid, it is reliable, but there are some questions about some of it, in particular about the medical model framework. Additionally, there has been criticism regarding the use of a categorical approach to diagnosis of disorders, which has been addressed in this new DSM-5. And we'll see what we can find out about some of these differences. Find a closer look in page 62, a little more detail about the differences. Now on the left is the DSM-4, and then on the right is the DSM-5. Now the DSM-4 was very categorical, and it made some of the diagnoses more like a box. You fit people in it and not sort of address the issues relative to people. And so let me back up a little, give you a little bit of background then. The DSM-5, it classifies as abnormal behavior patterns and mental disorders according to developmental models. This allows relevant lifespan information, which is a real important variable because psychological disorders over the lifetime, if someone is diagnosed in an early age in their 20s with schizophrenia, it doesn't mean that what they experience in their 20s will look the same in their 30s, 40s, 50s, and 60s. So a developmental lifespan is very critical. So this relevant lifespan information can be included in decisions regarding clinical diagnosis. The DSM-5 deliberately employs dimensions rather than categories in evaluating abnormal behavior. When a diagnosis of mental disorders is made, other pertinent details are gathered from the individual, such as psychological and environmental conditions, which influence the persistence of the disorder. You look at things like drug dependency, which fall in the DSM-5. Where you live, if you have a drug dependency and you live in the same area where you created or you established this drug dependency, then your environment is going to contribute to the continuation of a drug dependency. The impact the disorder has on areas of the individual's life are also documented. For example, a diagnosis of depression may have a significant influence on a student's ability to fulfill his or her own typical, role functions. The DSM-5 has undergone structural changes such as the elimination of the 5 levels of multi-axis system. In the DSM-4, there was a multi-axis system. It really said that there were 5 classes or 5 levels of contributing factors and limited it to 4, but you had these 5-axis system, and they've taken that out and replaced it. The major recognition of and regrouping of disorders has also occurred. There's some new disorders that have been included: disruptive mood, dysregulation disorder, premenstrual dysphoric disorder, and hoarding disorder. Asperger's syndrome was eliminated in favor of a broader category named autism spectrum disorder. And so one of the things that they argue in favor of the DSM-5 is that it's more relevant disorders to current time. It's not a general one like the DSM-4 was, which is a one-size-fits-all. Not all people who experience depression experience it in the same way, or their life experiences aren't the same. Now I'm going to revisit this issue of reliability and validity. That although reliability and validity are essential and have been considered, they are what some critics point to in regard to a diagnosis and treatment issues with the DSM-5. It is an issue for some clinicians, the degree of validity and reliability. Now, there is a cultural factor that DSM-5 is culture bound, and that is to say that there are syndromes that are specific to certain cultures but don't generalize to all cultures. These are patterns of psychological distress that are limited to one or only a few cultures. There's an example, and it's called TKS, and I'm sorry, I won't be able to pronounce it. You'll find it in your textbook. Is a common disorder in Japan. It's characterized by excessive fear that one will behave in an embarrassing way or in some way offend other people. And so these are some of the elements about the DSM system. What I want to go to next are treatments. Who provides treatments? Well, for the most part, mental health professionals, clinical psychologists, psychiatrists, social workers, people who are licensed mental health professionals, plus health professionals and counselors. Again, it's based on licensing. And psychotherapy is something that health professionals and counselors often use. Now, you could replace psychotherapy with the word talk therapy. And so it's important that you don't look to your neighbor for treatment or your best friend, because they're not clinicians, they're not expert in the field, and they bring a personal point of view, not a standardized perspective, to make decisions or recommendations. So let's begin our methods of treatment with biological therapies. The biological approach include drug therapy, electroconvulsive therapy, and psychosurgery. We'll begin with medication, where minor tranquilizers such as Valium may relieve short-term anxiety but don't directly help people solve their problems. And so we have in anti-anxieties often like things like Valium and Halcion are examples of anti-anxiety medications that are used as treatment for some psychological disorders. The antipsychotics, or neuroleptics, they help relieve flagrant psychotic features, but regular use of most antipsychotic drugs has been associated with risks of a disabling side effects one of which is known as tardive dyskinesia. Now, the antidepressant drugs, they've been shown to be very effective in treating depressive disorders. Lithium has been shown to be effective in treating bipolar. And so medication can have a role as long as the root of the problem for the individual is biological in nature. Now, it's not the only biological therapy. ECT, or electroconvulsive therapy, is often associated with dramatic relief from severe depression, but questions remain about its side effects. And essentially, it's kind of an old style where you would jolt the person with electricity, and it would sort of reset, if you will, the electrical settings within the brain. Again, for severe depression, it's had some degree of success. It's still being used today, but the side effects for some are more sketchy. Psychosurgery, it's not often used anymore. It's conducted only rarely because of its very adverse side effects. I didn't show you a real example of somebody experiencing what's known as a prefrontal lobotomy. What you're seeing is a long, slender instrument that would be inserted above the eye into the prefrontal lobe, and sweeping action would be taken to sort of disconnect. And it would certainly calm erratic behaviors, and there have been thousands of them done in Canada. It's just the adverse consequences of having it done is too severe. Now, there is a method that's called deep brain stimulation, and you're seeing an x-ray on the left of probes that have been put deeper into the brain, where implanting these electrodes within the part of the brain that affects mood. There is some positive effect for mood elevation for severe obsessive compulsive disorder and Parkinson's. However, it is limited and not approved for all other disorders, or for other disorders necessarily, like depression. And this is certainly, it's not as high risk as it may appear, and it seems to have some very desirable effects for some people. What I hope you're getting a feel for here is that one treatment does not fit all people. For some, there's a variety. You need to use a variety of treatments, and for others, there's some treatments that just won't be very effective for you. Now we move into the psychodynamic therapies. This is also, these are originated from psychoanalysis and Freud's work. The approach to treatment is developed by Freud. The psychoanalysts use techniques such as free association and dream analysis to help people gain insight into their unconscious and work through these conflicts they may experience in their unconscious in the light of in the light of adult personalities. Essentially, in free association, you continue to talk about whatever's on your mind. You just let your mind wander, and the therapist, who will sit out of sight from you, so they're not going to influence what you're going to say, and you might go through many sessions, but then the therapist will offer an analysis, of the patterns they've noticed or the disclosures that you've made, and drawing your attention to potential connections. Now, there is a risk with talk therapies and psychodynamic therapy, and that's known as transference. Through therapy, a client may not only interact with the therapist as a therapist, but at time also as other important people in their lives. And this can be helpful as in a role play circumstance, but it can also be problematic in terms of that client's other relationships when they expect the same level of caring and feedback they get from the therapist. And then lastly, there are certainly other more modern psychodynamic approaches, and these therapies are generally a lot briefer. The free association and other psychodynamic therapies can take years in some cases, but they tend to be briefer and less intense. They still tend to look to the unconscious, but they're more focused on the present. They sit face to face. They play more of an active and engaging role. Now, if we move into what are known as behavior therapies, there's a variety of things involved here. Behavior therapy applies principles of learning to help people make adaptive behavioral changes. These can include desensitization or a gradual exposure. And what's happening here is they'll get you to look at, a scale of rating of things that you could be doing in the order of which you get approach your phobia, say. So you might start by looking at a picture of a spider, and you may eventually work towards handling a spider. And this is systematic desensitization, or gradual exposure, where you break it, you expose yourself to that which you fear a little bit at a time, and then over time you can, reduce your fear. In some cases, they'll use a model, somebody who will demonstrate to you how to do it, and you can then repeat what they've done. And additionally, you might come across token economies. Now, you may have used this if you have been to any public schools. They use these quite a bit. Maybe in your public school experience, in order to read more books, you would gain stickers, and the more stickers you had, the more books you had read. And at the end of a period of time, when you had got a certain number of stickers, you'd get a reward. Well, that's a token economy system. And these are about trying to do social skills training. This would be around self-control techniques. You'd use some of these. So these would be different, again, a different type of therapy, again, using learning strategies. Now, more current strategies also include humanistic existential therapies. Now, humanistic approaches focus on the client's subjective, conscious experience in the here and now. Carl Rogers, who does person-centered therapy, helps people increase their awareness and acceptance of their inner feelings that had met with social condemnation and had been disowned in the past. Effective person-centered therapists possess the qualities of unconditional positive regard, empathetic understanding, and genuineness and congruence. Now, as we saw in week 1, we looked at emotion-focused therapy, and Dr. Glasser from York University, and his strategies are of this humanistic variety about gaining stronger emotional intelligence, which would be a healthier thinking and healthier experiencing in the here and now. Cognitive behavior therapies. Cognitive behavior therapies focus on modifying the maladaptive thinking or cognitions that are believed to be underlying emotional problems and self-defeating behavior. When we look at Ellis's rational emotive therapy, it focused on disputing the irrational belief that affect emotional distress and substituting adaptive behavior for maladaptive behavior. You're seeing an activating event that causes the C. Now, the Ellis view is Harry's belief. You have the activating event, and then you have the irrational belief. If you replace it with the rational belief, you get a different outcome. And that's changing the thinking, which was what makes it cognitive. And that because you have to act on that thinking, that's what makes it behavioral. When you look at Beck's cognitive therapy, he focuses on helping clients identify, challenge, and replace distorted cognitions. Now remember, cognitions means thinking, so distorted thinking, such as tendencies to magnify negative events and minimize personal accomplishments. So moving negative thoughts and changing them into positive thoughts. And this is a repetition or a practiced event. And Donald Mickelbaum, we talked about cognitive behavior management. He's got cognitive behavior therapy, where it's looking at the links and attempts to integrate the behavioral principles and cognitive techniques in a way to reduce or eliminate problematic behaviors and change dysfunctional thoughts and cognitions. So it's using the ability to use talk therapy, if you will, to change how we think and how we behave. Now, there are other other therapies, if you will. Eclectic therapy or the eclectic therapists make use of multiple models of psychotherapy. In clinical eclecticism, therapists use techniques from different approaches without necessarily adopting the theoretical model on which they were based. The integrative eclecticism, therapists attempt to synthesize and integrate diverse theoretical models. Now, we often have heard of the group or family or marital therapy, and this is important. Group therapy has several advantages over individual treatment, such as it reduces the cost, opportunities for shared learning and experiences, and mutual support, as well as an increased utilization of scarce resources, the therapist. The particular approach to the group therapy depends on the orientation of the therapist. Now, family therapists work with conflicted families to help them resolve their differences. Family therapists focus on clarifying family communications, resolving role conflicts, guarding against scapegoating individual members, and helping members develop greater autonomy. Whereas marital therapists focus on helping couples improve their communication and resolve their differences. Now, there is a relatively new or newer approach, which is computer-assisted interventions in therapy, and they come in all forms, from online cognitive behavior therapy with a live therapist using a video chat service to self-guided behavior therapy for children with anxiety. Computer-based interventions for various disorders have the potential to dramatically expand and alter the landscape in treatment. And I think it's probably worth noting as a reminder that not everything that you find online is an effective computer-assisted therapy. Do due diligence and use your critical thinking skills to determine whether or not what you're engaged in is legitimate. Now, the question then is begged, does psychotherapy work? Psychotherapy researchers have generated encouraging evidence of the effectiveness of psychotherapy, although there are few well-designed head-to-head comparatives. The results of meta-analysis of research studies compared psychotherapy with control groups. Control groups support the efficacy of various approaches to psychotherapy. The results of some 375 studies, controlled studies comparing various types of therapies, psychodynamic, behavioral, humanistic, and they did experimental versus control, which is very important. Experimental would be the groups that you're using the treatments with or the psychotherapy with, and control would be people who receive whatever help they normally get without getting any of the treatment, and they compared the two. Showed that the average psychotherapy client in those studies was better off 75% than the 75% of the clients who remained untreated. And that's pretty important. Now, in your textbook, you can read about Edmund Yu, that's page 83 to 84, as an example about, whether or not it works, but more so it fills in or fits in with the psychiatric commitment and patient rights. The legal process by which people are placed in psychiatric institutions against their will is called psychiatric or civil commitment. The psychiatric commitment is intended to provide treatment to people who are deemed to suffer from mental disorders and who to pose a threat to themselves or others. The legal or criminal commitment, by comparison, involves the placement of a person in a psychiatric institution for treatment who has been acquitted of a crime by reason of insanity. Three things need to be very imperative about that: clear evidence for this, an eminent risk factor, and on a limited time basis, not for long term. Voluntary hospitalization, people voluntarily seek treatment in a psychiatric facility, and they can leave on their own accord unless the court rules otherwise. So just as an example, I'm not sure how familiar you are with the guy on the right, but who's most dangerous when we think about patient and psychiatric issues? The person on the left, an apparently drunk driver, the institutionalized psychiatric patient in the middle, or the scheming corporate executive Bernie Madoff. He took $50 billion from friends and family and unsuspecting people in a Ponzi scam. So who's more dangerous? Well, you might, and this is part of what, in terms of a myth, some people would say that the institutionalized psychiatric patient is more dangerous. You could easily argue that the drunk driver is, and for that matter, Bernie Madoff might be. Lastly, but not least, although information disclosed by a client to a therapist generally carries the right of confidentiality, there was a case, the California Tereskov ruling, which held that therapists have a duty or an obligation to warn third parties of threats made against them by their clients. This does not apply in Canada. The question might be, will it ever? Maybe, maybe not. The right to treatment. Everybody has a right to treatment. The least restrictive, that means both in terms of the techniques used, that if the least restrictive strategy is the one we choose, and if it's on a larger scale, that we choose community over institution, and we choose all least restrictive when they are available or if it's possible. But people have a right to refuse treatment. And again, this is where Edmund Yu in page 3434 comes in. You could argue he would have benefited from treatment, but he was not of imminent risk, so he was allowed to refuse. Most people who are in need do not refuse. Well, I hope this has been helpful. The first two chapters are really just about introductory and getting a foundation or a basis, if you will, to understand what will be coming next. Week 3, we start looking at psychological disorders, and in particular, we're going to start with anxiety, obsessive compulsive, and trauma and stress-related disorders. All right, everybody, we're on our way. I hope you've been enjoying your semester, and I hope it goes all right. Please remember to get all your work done and make sure you book time for your online classes. Thank you. Bye now.